This lecture is entitled The Anatomy of the Thoracic Wall. My name is Carlos Andres Suarez-Quian. I am the creator and narrator of this lecture. Let's begin. Previously, we discussed the anatomy of the mammary gland and specific clinical aspects of its management when cancer strikes. Here, we discuss the thoracic wall per se, which exhibits three functions mentioned here: protection, help us to breathe, and serves the conduit for many important structures between the neck and the chest, and between the chest and the abdomen. In this first lecture on the thoracic cage, I will mainly explore the protective function of the thoracic wall. In the subsequent two sections of this series, I will discuss the anatomy of breathing and the thorax as a conduit. One would think that detailing the bones of the thoracic cage would suffice as an objective. However, there are details of the thoracic cage that become important for a physician to know to perform routine physical diagnosis. As such, I have listed here the objectives pertinent to gaining a complete understanding of the thoracic cage. I will not read them to you now. Feel free to stop the video and read them before proceeding with the rest of the presentation. Let's start the lecture by looking at the bones we find in the thoracic region. Here, we look at the thoracic cage from the front, the anterior view, and from the back, the posterior view. Let's name the bones. Looking at the anterior view, located just deep to the skin, we can feel the clavicle, a strut-like bone. On the posterior view, we can see the scapula. Although these two bones are found in the thoracic region, and hence we mention them here, these two bones act to help move the upper limb. They serve as important attachments for muscles that move the upper limb and will be discussed in more detail then. Instead, at this time, we will focus on the bones that make up the thoracic cage and how they serve to define the thorax, offer protection to the underlying organs, and assist with respiration. Lying in the middle portion of the thoracic cage is the sternum, and the sternum consists of three separate components: the manubrium, handle in ancient Latin, the body of the sternum, and the xiphoid process, resembling the tip of a spear or sword, and the reason for its name, albeit in ancient Greek. Next, we see the ribs, which in Latin is for to roof over. Note the first 7 ribs. They attach directly to the sternum by their own costal cartilages. Also note the spelling of the word costal. It is correct as written. The costal here refers to the Latin for rib, costa. Ribs 8 to 10 also attach by way of costal cartilages, but the costal cartilages of these ribs attach to the costal cartilages of the above ribs, and this creates a costal margin. Feel this in yourself at this time. The last 2 ribs, 11 and 12, are considered floating ribs because they have no distal attachment of the ribs to either the sternum or to costal cartilages. When we look at the region of the thorax from the back, we observe the vertebrae. These offer protection to the spinal cord, but also help define the region of the thorax. There are 12 thoracic vertebrae and are labeled in shorthand as T1 to T12. Note that a major characteristic of thoracic vertebrae is that their spinous processes overlap one another. this would not be a good region to try and reach a vertebral canal using a needle. Given that one function of the bones of the thorax is protection, it makes sense to mention what organs they are protecting. But first, let me explain some markings of the thorax of clinical relevance. Shown in this slide is the same anterior view of the thoracic cage as shown previously, but now a lateral view of the thoracic cage is shown also. In addition, I have placed a vertebral column in the image and labeled the thoracic vertebrae. It is customary in anatomy and medicine to relate the anterior components of the body to the vertebral levels in the back, as shown in this slide. For example, the upper part of the manubrium is known as the suprasternal notch. That is, the notch or indentation located above the sternum. Its posterior projection is at the interface between vertebral levels T2 and T3, where the inferior board of the manubrium meets the body of the sternum. An angle is formed, the sternal angle, or, as is known in the clinic, the angle of Louis. Its posterior projection is between T4 and T5. Importantly, it is where counting of the ribs begins. The cartilage of rib 2 joins at the angle of Louis, and it is the first rib that can be palpated. Rib 1 lies deep to the clavicle and cannot be felt normally. Where the body of the sternum meets the xiphoid, the suprasternal joint forms, and it projects posteriorly to vertebral level T9. The question now becomes, how can we use this information of where the parts of the sternum project posteriorly? The best way to answer this is to look at the surface projections of the heart. In the image, a heart and its great vessels are superimposed on the image of a model. Note the location of the heart vis-a-vis the projections we just discussed. As can be seen, the great vessels lie deep to the manubrium. The heart is located below the sternal angle and just above the suprasternal joint. And this might help you to appreciate the reasons for why CPR is performed by pounding the body of the sternum. First, that is where the heart is located. Second, by pounding on the sternum, you can compress the heart between the sternum and posterior vertebrae. But third, you try and avoid pounding on the ribs, which can crack, especially in the elderly, because the ribs have become more brittle. Understand that the thoracic cage protects all the contents of the thoracic cavity, specifically the heart and lungs. But because of the curved nature of the costal margin, some of the abdominal organs also extend deep into the thoracic cage and are protected by it. The normal liver, for example, lies under the right side of the thoracic cage. Indeed, if a physician can palpate a hard substance below the costal margin in an early patient visit and the patient smells of alcohol, it is likely that that individual is an alcoholic and is suffering from cirrhosis of the liver. The liver generally is not palpated below the costal margin except in children. Similarly, the stomach and spleen are protected by the lower half of the thoracic cage on the left, and even the kidneys are offered some protection by the rib cage. Let's now describe the ribs. We have 12 ribs on each side of the thorax, helping to protect the inner organs. Looking at the ribs as a group, however, it is clear that no two ribs are the same. Typically, we say that ribs 1 and 2 and 11 and 12 are atypical ribs. This is because ribs 1 and 2 are more curved than the typical ribs, and ribs 11 and 12 do not attach anteriorly. In contrast, ribs 3 to 10 are described as representing the typical ribs because they show the most uniformity as a group. Let's now examine the components of a single rib. The superior image is the superior view of rib 7, and the inferior view is the same rib, but the rib was rotated, so now we're looking at its interior surface. Each rib consists of a body, a neck, and a head. The head exhibits two facets for articulation with vertebrae. The superior facet articulates with the vertebrae above, and the inferior facet articulates with a vertebrae corresponding to its own number. Thus, rib 7 articulates with vertebrae 7 and 6. There is an angle to each rib. This angle keeps the rib from sitting flat on a tabletop and helps explain how the ribs begin a downward projection, then curve upwards on the body. This is a key feature you will learn to recognize in ribs when you study radiology. Another feature of ribs is the costal groove on the underside of the ribs. Remember, the rib is turned upside down so that the inferior groove is pointing upwards in this image. It is in this groove that the intercostal vein, artery, and nerve, in that order from superior to inferior, travel in the intercostal spaces and are protected by the ribs. This clinical pearl is exploited by clinicians when inserting a chest tube, as I will show you shortly. If I now zoom in on how the ribs articulate with the vertebrae, I can label a few additional features of the rib. For example, there's also a tubercle on the ribs for articulating with the facet on the transverse process of the corresponding vertebrae. Another feature of ribs that is of clinical significance is the way they attach to the sternum by way of the costal cartilages. The cartilage grants the ribs tremendous ability to be mobile, a feature of ribs not easily appreciated when you first observe the ribs attached by wires on a skeleton. Let's see how this mobility of ribs is exploited during a thoracotomy, or an operation in which the chest cavity is open. In a typical thoracotomy, a wide oblique incision is made on the lateral chest, and the skin and the superficial fascia are retracted. The next step is to make an incision on the periosteum encasing a particular rib. For reference point, an intercostal and the periosteum are labeled. Next, part of the rib is removed. The rib will be secured and kept in a sterile environment. A rib spreader will be placed inside the cut periosteum to spread the ribs wide. Again, this is possible because of the high mobility granted to the ribs by the costal cartilages. The large opening made now allows the surgeon entry into the thoracic cavity. Let me label the numerous structures visible from this lateral entry into the thoracic cavity. First, I will indicate the principal organs that surgeons must avoid injuring during a thoracotomy. the lung, and the pericardium encasing the heart. The parietal pleura needed to be cut to expose the lungs. Prominent bony structures include the scapula and the cut sixth rib. The prominent phrenic nerve running anterior to the root of the lung is clearly visible, as is the superior vena cava. Surgeons must be careful also not to damage the trachea and the esophagus found in this area. Using this approach, complete lungs can be removed in this way, or large malignant tumors. What is clear from this example is how the structure of the thoracic cavity has been exploited to surgically manage the patient. The resiliency provided to the ribs by the costal ligaments invariably helps prevent more frequent rib fractures. However, if you try hard enough, you can break a rib. Broken ribs are most commonly caused by direct impacts, such as those from motor vehicle accidents, falls, child abuse, or contact sports, such as football. The ribs will usually fracture at the angle or just anterior to it. Think for a moment, however, why is it that football quarterbacks do not sustain even more rib fractures than they do when being violently tackled on the football field? There are two answers actually. First, they wear flak jackets to help absorb the blow of the massive linemen going after them. But the second reason is, again, the resiliency afforded to the ribs by the costal ligaments. Let me list some features of ribs to explain in part how rib injuries present. As mentioned for the football quarterback, costal cartilages provide resilience to the rib. Because of elasticity of cartilages in children, compression may cause injury to organs, yet ribs will not be broken. The first rib is the least likely to be damaged, not only because it is broad and flat, but it is protected by the clavicle. Ribs 2 to 7 are the most likely to be broken just anterior to the angle. A special kind of rib fracture, and one that generally requires immediate treatment, is flail chest. This occurs when multiple ribs fracture. In this situation, paradoxical movement of ribs during breathing takes place. That is, the broken segment of ribs is inhaled when the chest expands to breathe. The jagged edge of the broken bones may damage the underlying lung lining and induce a life-threatening pneumothorax. Flail chests are quite dangerous and require immediate treatment. In old age, costal cartilages may undergo progressive ossification, becoming radiopaque, and give rise to some confusion in chest films. Rib fractures can be discerned in conventional chest films. Look closely at the two films. On the left, I show a normal chest film. On the right, the arrows mark where multiple rib fractures are present, including a fracture of the clavicle. With experience, you can easily detect these fractures. And to show you the importance of the costal cartilages in maintaining resiliency and what can happen when these properties are lost in the aged individual, here's an image of an elderly person who suffered broken ribs. He was entering an elevator when the door suddenly closed and the rubber bumper of one side pushed him against the other side. This trauma alone led him to fracture his ribs. Let's now mention some clinical facts about the sternum. Despite its subcutaneous location, The sternum is rarely cracked. Again, this is because the sternum is well protected by the costal cartilages on either side. However, when damaged, the concern is not for the sternal injury, but for the likelihood of heart injury. Remember what organ is being protected by the sternum. In fact, mortality associated with sternal fractures is reported to be 25 to 45%. Patients, on the other hand, recover nicely from rib fractures. Finally, even though it's easy access, the sternum has stopped being a common site for bone marrow extraction. Nearby large blood vessels can be a complication. The last topic to discuss of the thoracic wall is its blood supply, and one word defines it: segmental. On the left, I show a drawing of the thoracic aorta. Note how from the back, small segmental vessels leave the aorta. These arteries will ultimately enter between two muscle layers. We will describe these in the next section. Suffices to say now that they are intercostal muscles. Then, the vessels travel under the corresponding rib, protected by the grooves of the ribs. These segmental vessels are called posterior intercostal arteries. For reasons that depend on development, the first two intercostal vessels are branches of the superior intercostal artery that in turn arises from the costocervical trunk, a branch of the subclavian artery. All other posterior intercostal arteries are direct branches from the aorta. Since the aorta resides on the left side of the thoracic cavity, the right posterior intercostal arteries are somewhat longer than the ones on the left. The 12th posterior intercostal artery is given the name of subcostal. In addition, other branches can be seen to arise from the thoracic aorta, but these go to the esophagus and are called esophageal arteries. The anterior intercostal arteries, shown on the right-hand image, are branches from the internal thoracic artery, and they too are segmental. This is the same artery that fed the breast as well as the sternum. The veins of the thoracic wall are also segmental vessels. Let me first label the two main veins seen in the drawing, the superior and inferior vena cava. On the right side of the body, the intercostal veins drain to the esophagus vein, the vein without a twin, that ultimately will empty into the superior vena cava. From the left side of the body, the pattern is not consistent. Several of the intercostal veins coalesce into a single vessel termed a hemiascus vein. These veins can cross the midline of the body. It is possible to have more than one hemiascus vein. The lymphatic drainage from the thoracic wall is fairly straightforward in terms of where it goes. Lymphatic vessels of the thoracic wall drain mainly into lymph nodes associated with the internal thoracic arteries, the parasternal nodes, nodes found near the head and neck of the ribs, and with nodes near the diaphragm. These details are important to an oncologist. The intercostal nodes of the lower thorax drain into the thoracic duct, now labeled, that runs parallel to the ascus vein. Those in the upper nodes will enter to drain deep within the chest. Again, these details are important for the cancer specialists. Once again, let me remind you of the arrangement of the intercostal veins, arteries, and nerves in association with the ribs. Zooming in on the enclosed area, The vein, artery, and nerve are located inferior to the corresponding ribs and run within the costal groove. The posterior intercostal veins on the left, as stated previously, will drain to the hemiacegus vein. This now completes the first section of the 3 parts on the thoracic wall.